Okay, let's unpack this. Welcome back to the deep dive. Today, we are really going deep into the body's response to, well, to crisis. We're talking about that physiological earthquake, the one that happens inside a patient right after major trauma or surgery. And this isn't just like simple wound healing. We're looking at the metabolic aftershock. It's this huge systemic response, really complex, and sometimes, frankly, self-destructive. It basically governs whether our patients are going to thrive or fail in critical care. So our mission today, this is really for you, the clinician listening. We want to synthesize a detailed, kind of integrated picture of all those systemic physiological biochemical changes that follow injury. We need to get past just the basic categories and dive into the neurohormonal switches, the inflammatory mediators, the dams, the pathways, and figure out the practical clinical implications of this whole unified stress system.
Yes, exactly. And to jump right into that idea of integration, we're really looking at the surgical stress response, not just as a reaction, but as an integrated system. It involves neurohormonal bits, inflammatory circuits, neural circuits all working together, or sometimes against each other. And understanding this system is absolutely crucial because these fundamental changes, we're talking profound catabolism, immune dysfunction, huge fluid shifts, these are the core challenges in managing major trauma, sepsis, complex perioperative care that profoundly impact recovery, long-term outcomes, and ultimately survival itself. Okay, so to lay the groundwork, let's start with homeostasis. That's the core idea, right? Maintaining that constant internal environment so cells can function optimally. Now, when you introduce major trauma, severe injury, or extensive surgery, the body sees this as an immediate existential threat. It just violently disrupts that finely tuned balance.
Right, everything gets thrown off kilter.
Precisely. And the body's initial metabolic response, it's traditionally split into two main phases. First, there's that initial acute, very defensive phase, sometimes called the ebb phase, often involves a period of shock. And its characteristics, well, you see immediate conservation efforts. Hypovolemia, a decreased basal metabolic rate, the BMR, reduced cardiac output, often hypothermia, and frequently lactic acidosis.
So clinically, that's the body just slamming on the emergency brakes. It's immediate, almost primal, all about survival, prioritizing blood flow to vital organs, trying to survive that initial hit like hemorrhage.
Exactly right. Its physiological role is purely survival in that moment, conserving circulating volume, rationing energy stores like crazy. But, and this is key, this phase is accompanied by this massive, urgent neurohormonal firing. And that neurohormonal surge is what kicks off the systemic inflammatory response syndrome, or SIRS. Now, mobilizing body stores is life-saving initially, but if it goes on too long, that's where the negative consequences pile up. Rapid muscle breakdown, weight loss, and critically persistent hyperglycemia. All these things dramatically increase the risk of complications, especially infections.
Okay, so that's the ebb phase, the initial shock. Then, assuming successful resuscitation, controlling bleeding, the patient shifts gears
Right?
into the second stage.
That's right. Once the ebb subsides, hopefully the patient transitions into what's often called the flow phase.
Yeah.
This is actually the hypermetabolic phase, the opposite of the ebb in terms of energy expenditure. And it's all focused on rebuilding tissue repair, restoring the body mass that was lost during that acute insult.
So repair mode kicks in.
Yes, but this phase, characterized by that heightened metabolic activity, can unfortunately last for weeks, even months, after a really serious injury. The body is desperately trying to restore lost lean tissue and fix all the systemic damage. It's a long haul.
And here's where, modern medicine throws in a twist. The sources really highlight this contrast. In our trauma centers now, we're actually incredibly good at managing that immediate crisis, the bleeding, the initial shock. So paradoxically, most hospital deaths after major trauma don't happen right away anymore. They happen days, sometimes weeks later. And they're the result of these complex, often uncontrolled physiological processes we're discussing, specifically multiple organ dysfunction syndrome, MODS, and secondary sepsis.
That is the critical challenge, isn't it? We stabilize the patient from the immediate threat, but then this uncontrolled metabolic cascade, the body's own response, becomes the major risk factor. Even with everything we can do, the mortality for MODS is still stubbornly high, around 25%. It's like the body's protective system overshoots and causes collateral damage.
And this understanding, this devastating reality, really forms the foundation of modern surgical thinking. The big push towards stress-free perioperative care, things like enhanced recovery after surgery ERS protocols, it's all about actively trying to reduce the severity of that initial homeostatic disruption. The idea is, If you can minimize the initial insult, maybe through minimal access surgery, better pain control with regional blocks, keeping the patient warm, you drastically reduce the intensity of the SIRS the body feels it needs to launch. Less trigger, less response.
Exactly. And it's important to remember this response isn't just on or off, it's graded. A simple elective procedure, say a lap col, might cause just a modest temporary blip in inflammatory markers and temperature. But major trauma, severe sepsis, extensive burns, they push the system much harder. They accentuate all those changes dramatically, leading directly to profound hypermetabolism, catastrophic catabolism, severe shock, and MODS.
Whoa.
The bigger the injury, the deeper the metabolic hole the patient falls into.
And I think maybe the most crucial detail here for us clinicians, the thing that makes standardized treatment so tricky, is that genetic variability plays a huge role. Even with similar injuries, the intensity of that inflammatory response can vary significantly between individuals.
That's a really critical point, because if genetics are so important, it challenges our current, maybe somewhat generalized approach based on just SIRS or CARS categories. Are we trying to apply one-size-fits-all treatments when two patients, same injury on paper, might have wildly different internal inflammatory trajectories, one rocketing towards hyperinflammation, the other towards immune paralysis or CARS? Figuring out that individual response is probably the next big challenge. Okay, so let's zoom in now. What actually triggers and keeps this whole cascade going? Let's look at the molecular and hormonal orchestrators, starting right at the moment of tissue breakdown. #tag tissue damage in the inflammatory cascade. DAMPs, right? So when tissue gets damaged, could be a surgical cut, a crush injury, a burn. The body doesn't necessarily need bacteria to sound the alarm. It senses the damage through the release of internal molecular bits and pieces from damaged or dying cells. These are called damage-associated molecular patterns, or DAMPs. Sometimes people call them alarmins, which is quite a vivid term, actually.
Yeah.
Alarmins, like internal smoke alarms going off everywhere. So these DAMPs are the body's internal emergency call, basically yelling, "System failure." What are the key molecules we should be thinking about floating around in the plasma?
Well, the key players are molecules that should be inside cells but are now inappropriately exposed. Things like heat shock proteins, high mobility group protein, B1, HMGB1, S100 proteins, even fragments of DNA or RNA. And these are immediately sensed by really sophisticated cellular sensors called pattern recognition receptors, or PRRs. The toll-like receptors, NOD-like receptors. They sit strategically on our innate immune cells, macrophages, neutrophils, dendritic cells, the first responders on the scene.
And that sensing, like DAMP binding to a PRR, that's what lights the fuse for this massive systemic inflammation we see. How fast does that signal actually translate into a full-blown response? Because clinically, it feels almost immediate sometimes.
It is incredibly fast, nanoseconds really, for the initial binding. That PRR activation triggers the rapid assembly of these complex protein machines inside the cell called inflammasomes. This assembly then leads to the activation of powerful enzymes, specifically caspases. And these caspases, in turn, cleave and activate the key pro-inflammatory cytokines, interleukin-1, IL-1, interleukin-6, IL-6, and tumor necrosis factor alpha, TNFi, plus others like interferons and chemokines. This sequence is the immediate start of a sterile systemic inflammatory cascade, sterile meaning caused by the injury itself, not bacteria that results in SIRS. The window to intervene pharmacologically right at this trigger point is probably minutes, maybe seconds, not hours.
Wow. And that sterile inflammation, if it gets out of control or lasts too long, that's where the real danger lies clinically, isn't it? It becomes a major risk factor for that cascade of organ failure. AKI, ARDS, coagulopathy, MODS, even secondary brain injury.
Exactly. And what makes tackling this so frustrating from a therapeutic standpoint is the concept of molecular redundancy. These DAMPs can trigger several different receptors, and the signals can travel down multiple pathways inside the cell. This crossover means that blocking just one pathway often doesn't shut down the whole inflammatory response. Another pathway just compensates. It's like trying to dam one tributary when the whole river is flooding. Plus, the process can feed itself. Dying cells release more DAMPs, amplifying the inflammation.
And we absolutely cannot forget those secondary triggers, things that will pour gasoline on the fire if we don't get them under control quickly. We're talking ongoing sepsis, obviously, but also hemorrhage, massive transfusion reactions, severe acidosis, crush syndrome, or ischemia reperfusion injury after restoring blood flow. These aren't just happening alongside the inflammation, they actively maintain and amplify it, locking the patient into that prolonged catabolic state. #B, the neuroendocrine pathways.
Okay, so moving from the immediate local molecular alarms, the DAMPs, up to the central command center, the neuroendocrine system obviously jumps into action with that classic fight-or-flight stress response.
Yes, this is a rapid communication highway. those afferent pain nerves, the nociceptive neurons, get excited by the local inflammation and tissue damage. They send signals racing up to the hypothalamus. This triggers the release of corticotropin-releasing factor, CRF. CRF then tells the anterior pituitary to release adrenocorticotropic hormone, ACTH. And ACTH hits the adrenal glands, causing that dramatic surge in cortisol secretion, often peaking just hours after the initial injury.
The classic HPA axis activation.
Precisely.
Yeah.
And at the same time, that hypothalamic activation fires up the sympathetic nervous system. You get release of adrenaline, epinephrine, both locally from nerve endings and systemically from the adrenal medulla, and it also stimulates glucagon release from the pancreas. The sources are quite clear on this. If you experimentally give a high-dose cocktail of these counter-regulatory hormones, cortisol, glucagon, catecholamines, you can pretty much reproduce all the metabolic features of the injury response. They are incredibly powerful drivers.
So the immediate job of this hormonal surge is just pure energy mobilization, right? Override everything else.
Absolutely. They're liberating huge amounts of glucose from glycogen stores, then initiating the breakdown of fat, lipolysis, and protein, proteolysis. The goal is just flood the system with metabolic fuel glucose, fatty acids, amino acids for immediate energy needs and for the building blocks needed for repair, even if it means sacrificing lean tissue long term. Now, for clinicians managing these patients day to day, it's really vital to grasp that this neuroendocrine response is distinctly biphasic. It changes over time.
Absolutely critical point. The acute phase, lasting hours, maybe a day or two, is defined by those soaring levels of counter-regulatory hormones. And generally, that's thought to be beneficial for immediate survival, maximizing cardiac output, mobilizing fuel. But if the injury is severe or the stress becomes protracted, we shift into the chronic phase. This can last days or weeks. And here, you often see hypothalamic suppression. The central drive decreases, leading to lower serum levels of the target organ hormones, things like thyroid hormones, anabolic steroids like testosterone. And this chronic low-level hormonal state is thought to directly contribute to the problems we see in chronic critical illness, the persistent wasting, the immunosuppression, maybe even some of the cognitive dysfunction. ###C. The complex interplay, cytokines and hormones.
Right, so it's not like these are two separate tracks running in parallel, the cytokine track and the neuroendocrine track. They're constantly talking to each other, amplifying each other's effects, aren't they?
Oh, absolutely. It's a complex feedback loop, often a vicious one. Those initial pro-inflammatory cytokines we mentioned, IL-1, TNF-I, IL-6, IL-8, they're produced really rapidly within the first 24 hours usually, and they act directly on the hypothalamus. They contribute to the fever, the pyrexia we see, by affecting central thermoregulation. And crucially, they augment the hypothalamic stress response, essentially telling the brain, keep pumping out those stress hormones.
It really is a full-body assault then.
It is. And furthermore, these cytokines don't just act centrally. They have direct effects on peripheral tissues too. They directly trigger proteolysis in skeletal muscle, that muscle breakdown we keep talking about. And simultaneously, they drive that acute phase protein production in the liver. A great example of this synergy is cortisol. Now, we think of high cortisol as immunosuppressive generally, but in this context, it acts powerfully together with IL-6 to ramp up the hepatic acute phase response. It helps the liver reprioritize the entire body's protein metabolism towards making inflammatory and repair proteins.
And we touched on this earlier, but it bears repeating. The hyperglycemia itself isn't just a passive symptom of all this stress. It's an active participant, actually making things worse.
Yes, that's a critical clinical insight. Hyperglycemia actively aggravates inflammation, especially at the mitochondrial level inside cells. When you have high glucose flux, it generates excess oxygen-free radicals, those reactive oxygen species, ROS. High glucose also alters gene expression in ways that enhance further cytokine production. It literally creates a self-sustaining vicious cycle. High blood sugar fuels the inflammation that caused the high blood sugar in the first place. And, given the sheer molecular complexity, network analyses show changes in over 3,700 genes in white blood cells just from endotoxin exposure. This complexity is exactly why trying to find a single magic bullet molecular therapy has proven so difficult. It emphasizes why optimal clinical care, managing the whole physiological milieu, temperature, fluids, glucose, nutrition, minimizing secondary insults, is likely more effective than targeting one specific molecule right now. #the agonists, antagonists, and immune dysfunction.
Okay, so if this inflammatory cascade, SIRS, were just allowed to run completely rampant, the patient would crash and burn pretty quickly from MODS. The body must have some kind of braking system, right? A control mechanism.
It does, thankfully.
Yeah.
And the resolution, the braking, starts almost immediately alongside the acceleration. You see a mirror image response. Within hours of those pro-inflammatory cytokines ramping up, endogenous antagonists start appearing in the circulation. We see molecules like interleukin-1 receptor antagonist IL-1RA, which literally blocks the IL-1 receptor. We see soluble forms of the TNF receptor, TNF-SR55 and 75, that soak up circulating TNF-A. These act quickly to try and put the brakes on SIRS signaling and limit that systemic organ damage.
So there's an anti-inflammatory response kicking in right away.
Yes. And locally, within the tissues, the cleanup is orchestrated by another fascinating group of molecules, the specialized pro-resolving mediators, or SPMs. These are derived from essential fatty acids, things like lipoxins, resolvins, protectins. Their job is to manage the crucial resolution phase, clearing away dead cells and debris, promoting the uptake of apoptotic neutrophils by macrophages, a process called efferocytosis, and actively signaling for the inflammation to stop. They're like the cleanup crew and the ceasefire negotiators combined.
Okay, so SIRS is the fire alarm and the initial uncontrolled blaze. The antagonists and SPMs are the firefighters and the cleanup crew. But what happens if the anti-inflammatory response, the firefighters, work too well? Or maybe they overreact relative to the initial fire?
That is the flip side of the coin, and it leads to the second major syndrome we worry about, compensatory anti-inflammatory response syndrome, or CARS. If this anti-inflammatory phase becomes dominant perhaps after a really severe injury, major hemorrhage, or maybe just due to individual genetic predisposition, it results in profound systemic immunosuppression. The patient essentially becomes immunoparalyzed, and the consequence, they become incredibly susceptible to opportunistic infections, often with bugs that would normally cause problems. This can lead to severe secondary sepsis. This state, often combined with the persistent catabolism, is what we now often call PICS, persistent inflammation, immunosuppression, and catabolism syndrome. It's that challenging state of chronic critical illness where patients just can't seem to recover.
This really highlights the tightrope walk for the patient, doesn't it? They have to navigate this narrow channel between the dangers of too much inflammation, SIRS leading to MODS, and the dangers of too much anti-inflammation, CARS leading to sepsis and PICS. And critically, as you mentioned, both the intensity of SIRS and the intensity of CARS seem to be subject to that individual genetic variability, makes managing these patients incredibly complex. Right, let's shift our focus now to the really tangible, often devastating effects that these hormonal and cytokine storms have on the body itself. This is where we see that phase sometimes graphically called autocannibalism, #A, catabolism, hypermetabolism, and insulin resistance. So after we've hopefully gotten the patient through that initial ebb phase, stabilized them, they enter this hypermetabolic flow phase. And the intensity of this phase really mirrors the severity of the SIRS response they experienced. What are the key things we actually see at the bedside that tell us this hypermetabolism is raging?
Well, the classic clinical signs are pretty obvious once you look for them. Significant tissue edema is common from all that ongoing capillary leakage. You see a sharply increased basal metabolic rate, true hypermetabolism, maybe 15%, 25%, sometimes even higher above their predicted resting energy expenditure. You also typically see increased cardiac output, a raised core temperature or fever, leukocytosis, high white cell count, and importantly, evidence of increased oxygen consumption and increased gluconeogenesis. The liver is just churning out glucose. They're essentially running their internal furnace on high, but very inefficiently.
What's actually driving that furnace? Why is the metabolic rate so high?
It's driven by several things acting together. That central thermodysregulation caused by circulating cytokines is a big part of the fever itself costs energy. Then there's the increased sympathetic activity, all that adrenaline release. And interestingly, abnormalities in wound circulation contribute too. Areas that are ischemic or poorly perfused produce lactate. This lactate travels to the liver, which then has to convert it back to glucose via the Cori cycle. And the Cori cycle is notoriously energy expensive. It significantly adds to the body's overall oxygen consumption and heat production.
But the sources mention something interesting, that the theoretical maximum level of hypermetabolism isn't always what we measure. Our own ICU care can dampen it down a bit.
That's a really important point for interpreting metabolic studies, yes. Think about standard ICU care. We often have patients on bed rest, sometimes chemically paralyzed, mechanically ventilated, which reduces work of breathing, and we actively manage their temperature with cooling or warming blankets. All these interventions actually limit the body's total energy expenditure compared to what it might be if the patient were, say, shivering uncontrollably or thrashing around. So measured hypermetabolism might actually underestimate the underlying drive, which is something to keep in mind.
Okay, now let's tackle the big one, the clinical challenge that dominates so much of our time in critical care and contributes so heavily to poor outcomes: insulin resistance and hyperglycemia. Why does the body lose control of blood sugar so dramatically in this state?
It's almost entirely driven by that toxic cocktail of counterregulatory hormones, cortisol, glucagon, catecholamines, and the inflammatory cytokines, particularly TNF-A and IL-1. These agents directly interfere with the insulin signaling pathway in peripheral tissues like muscle and fat. They basically block the door, preventing glucose from getting into the cells even when insulin is knocking. This leads to profound peripheral insulin resistance. Initially, insulin levels might even be low due to sympathetic inhibition, but later, even if the pancreas ramps up insulin production, it's just not effective at the cellular level. And as you expect, the degree of insulin resistance is almost always directly proportional to the severity of the injury or sepsis. More stress, more resistance.
And as we established, this isn't just a number on the glucometer we need to chase. This poor glycemic control, especially when combined with that ongoing catabolism, significantly increases the risk of septic complications. It fuels that vicious cycle involving mitochondrial stress and ROS production we talked about.
Precisely. Which is why the cornerstone of management for decades has been aggressive IV insulin infusion to treat and maintain blood glucose within a reasonable range. However, we also learned the hard way, particularly from the NICE sugar trial, about the serious dangers of overly tight control. Trying to force glucose levels down too low significantly increases the risk of severe, potentially lethal, iatrogenic hypoglycemia. So the balance is absolutely critical. We need to control the hyperglycemia to mitigate its pro-inflammatory effects, but without causing dangerous lows. Current thinking generally favors slightly looser glucose targets than perhaps were aimed for 10 or 15 years ago. It's a constant balancing act. Hashtag has a skeletal muscle wasting. The autocannibalism.
Okay, let's talk about maybe the most dramatic and frankly visually distressing physiological outcome of this whole stress response. The profound skeletal muscle wasting. This really represents the body making some brutal choices about resource allocation.
It is the ultimate metabolic reprioritization. The body essentially decides that peripheral tissues, skeletal muscle, fat stores, even skin to some extent, are less critical for immediate survival than the central players. So it forcefully redirects the limited metabolic building blocks away from these peripheral stores and mobilizes them towards the key central viscera, the liver, which needs amino acids for that massive acute phase protein synthesis, the immune system, which needs fuel and components to function, and of course the active wound site itself, which needs resources for healing.
The sources quantify this loss in really stark terms. Can you give us a sense of the sheer magnitude of protein that can be lost? It's quite shocking.
It really is. In severe states like major sepsis or extensive burns, the measured urinary nitrogen losses can hit 14 to 20 grams per day. Now, you have to remember that nitrogen loss correlates directly with the breakdown of lean body mass. So 14-20 grams of nitrogen per day translates to the destruction of roughly 500 grams of wet skeletal muscle every single day. Half a kilo of muscle gone.
Half a kilo a day, that's staggering.
It is. Think about that accumulating over a week or two in the ICU. And crucially, the sources really emphasize this. This relentless muscle breakdown cannot be fully stopped just by giving artificial nutrition, whether it's TPN or enteral feeding. As long as that underlying severe systemic stress response, the SIRS or sepsis, is still raging, you have to control the inflammation first.
That really underscores the idea that nutritional support during the acute severe phase is more about mitigating losses, being permissive rather than expecting to build muscle back until the inflammation cools down. So let's get into the nuts and bolts. How is the muscle actually being destroyed at the molecular level?
Okay, so we're fighting specific molecular machinery here. Muscle wasting happens because you get a massive increase in the rate of muscle protein degradation combined with a simultaneous decrease in the rate of muscle protein synthesis. It's a double whammy. And the predominant mechanism driving the breakdown, the one that requires energy, ATP, is the Ubiquitin-Proteasome pathway.
The Ubiquitin-Proteasome pathway. Okay, break that down for us. What does that actually mean inside the muscle cell?
Right. So ubiquitin is a small protein that acts like a tag or a label. Specific enzymes attach multiple copies of ubiquitin to proteins that are targeted for destruction. Then, this large molecular machine called the 26S proteasome recognizes this ubiquitin tag. Think of it like a cellular recycling center or shredder. It grabs the tagged protein, unfolds it, and chops it up into small peptides and amino acids, which can then be released from the muscle cell. Other pathways, like lysosomal cathepsins and the calcium-dependent calpain system, play supporting roles, but the ubiquitin-proteasome system is really the main engine of this accelerated catabolism, and it's fueled by the energy available in that hypermetabolic state. Furthermore, to get crucial amino acids like glutamine and alanine out of the muscle, often needed by the gut and liver, The muscle has to irreversibly break down its own branched-chain amino acids. This ensures a net loss of protein from the muscle.
And the clinical consequence of all this, it's not just looking thin.
Oh, absolutely not. The clinical consequences are profound. Severe weakness, inability to participate in physical therapy, reduced functional ability long after discharge, difficulty weaning from mechanical ventilation due to respiratory muscle weakness, increased risk of complications like pressure sores and hypostatic pneumonia. It directly impacts morbidity and mortality, both short-term and long-term. Hashtag TACE. Alterations in body composition and hepatic response.
Let's look at the bigger picture of body composition. We know protein is the main resource the body draws on besides fat. What are the critical thresholds here?
Right. Protein is the main labile reserve, meaning it can be broken down and mobilized relatively easily, unlike, say, structural components. The average 70-kilogram man has about 12 kilos of total body protein, most of it in muscle. The sources state pretty bluntly that survival becomes unlikely if total body protein mass loss reaches about 30% to 40%. There's a simple rule of thumb often used. The loss of just 1 gram of nitrogen in the urine corresponds to the breakdown of about 36 grams of wet weight lean tissue. So those high nitrogen losses we discussed translate into massive tissue destruction.
And while the muscle is being broken down, the liver is doing the exact opposite, right? It's ramping up production in the hepatic acute phase response, APR.
Exactly. It's another massive reprioritization, this time of protein metabolism, shifting the focus squarely onto the liver. And this is driven primarily by that cytokine IL-6 acting synergistically with cortisol, as we mentioned.
So this APR involves a clear trade-off. The body makes certain proteins at the expense of others. What are the key players here?
We usually categorize them as positive and negative acute phase reactants. The positive reactants are proteins whose plasma concentrations increase dramatically during stress. Classic examples are fibrinogen, involved in clotting, and C-reactive protein, CRP, which we measure all the time. The levels of these can shoot up by hundreds or even thousands of %. This surge provides proteins needed for host defense, coagulation, wound repair, limiting tissue damage. But, and this is the crucial trade-off, the amino acids needed for this rapid synthesis are ripped primarily from peripheral lean tissue, mainly muscle. Conversely, the negative reactants are proteins whose plasma concentrations decrease. The most prominent example, the one we track closely, is albumin. Its levels drop sharply in critical illness.
Now, you mentioned a critical clinical nuance here about why albumin drops. It's often misinterpreted on rounds, isn't it?
Yes, very often. The common assumption is that the liver is failing, or synthesis is just shut down. But actually, reduced hepatic synthesis only accounts for a relatively small part of level plummet is due to something called the increased transcapillary escape rate, or T.
Tear. Okay, that's the leaky pipes phenomenon again, isn't it? Can you give us a sense of how leaky things get?
Exactly. The systemic inflammation makes the tiny blood vessels, the capillaries, much more permeable. So albumin, which normally stays mostly within the vascular space, starts leaking out rapidly into the surrounding tissues, into the interstitium. Following major injury or sepsis, this tear can increase by as much as threefold. So 3 times the normal rate of albumin is escaping the circulation. That's why the serum level drops so fast. And the key clinical insight here is that just pouring more albumin solution into the patient to correct the low albumin level is often like trying to fill a leaky bucket. It might raise the level temporarily, but it doesn't fix the fundamental problem, which is the leakiness of the capillaries due to ongoing inflammation. Plus, it just adds to the tissue edema.
Which brings us neatly to that final clinical paradox. The critically ill patient, who often looks swollen, gains weight on the scales, but is simultaneously melting away internally, losing critical protein mass.
Yes, I think every clinician has seen this. Patients who look visibly puffy, maybe they're up 8, 10 kilos, even more from their admission weight, yet their serum albumin is in the boots, and they're profoundly weak. This weight gain is almost entirely due to the aggressive fluid resuscitation we have to give, especially early on, to manage shock and maintain organ perfusion. The body weight shoots up immediately, largely due to a massive expansion of the extracellular water compartment, maybe 6 to 10 liters or more within the first 24 hours. So they are physically heavier because they are holding on to resuscitation fluid, they're edematous, but at the same time, their total body protein mass is diminishing significantly. You might see a 15% loss of body protein over just 10 days in a severe case. And this is exactly why modern elective surgery protocols like ERS put such a heavy emphasis on rigorously avoiding this excessive fluid administration and weight gain by carefully limiting IV crystalloids. That fluid overload significantly contributes to visceral edema, gut dysfunction, and prolongs recovery.
Okay, so wrapping all this understanding together, our primary goal as clinicians managing these patients has to be limiting or controlling all those factors that prolong the acute phase response. If we can't always prevent the initial damp release from the injury itself, we absolutely must be aggressive about controlling the secondary hits, those compounding factors. Hashtag A, avoidable factors, compounding the response.
Yes, we need to be relentlessly vigilant about controlling a specific list of factors that we know exacerbate and prolong the stress response. This applies equally in elective surgery planning and in emergency resuscitation. The list includes things like ongoing hemorrhage or any kind of under-resuscitation causing volume loss, any degree of hypothermia, uncontrolled tissue edema from over-resuscitation, persistent tissue underperfusion or shock, prolonged starvation, and that includes unnecessarily long preoperative fasting periods, immobility, and critically uncontrolled pain. Each of these acts like pouring fuel on the existing fire.
Let's zero in on starvation for a moment. It's almost endemic in the surgical patient experience because of NPO orders and gut dysfunction. We need to really highlight the metabolic difference between just simple fasting, like skipping a meal, versus starvation combined with injury or sepsis.
That distinction is absolutely crucial. During simple, uncomplicated starvation, say, so when fasting electively, the body needs about 100 grams of glucose per day, primarily for the brain. Initially, it uses up its glycogen stores. Once glycogen is gone, after maybe 12-24 hours, the liver kicks in with gluconeogenesis, making new glucose mainly from amino acids, from muscle breakdown initially, and lactate. But the key adaptive process in simple starvation is that the body rapidly attenuates nitrogen loss. It switches its primary fuel source to mobilizing fat stores, ketones, and becomes highly metabolically efficient at conserving lean body mass, preserving protein.
But injury throws a wrench in that adaptation.
Completely. Injury or sepsis fundamentally prevents that normal adaptive switch to efficient fat burning and protein sparing. That hormonal and cytokine storm we discussed effectively overrides the body's ability to conserve protein. So the injured or septic patient remains stuck in this state of ongoing high-rate autocatabolism. They are forced to continue breaking down lean tissue at an unsustainable rate to provide glucose via gluconeogenesis and those essential amino acids needed for the inflammatory response and tissue repair. They can't make that efficient switch to fat metabolism. This is precisely why early nutritional support, preferably via the enteral route if the gut works, is considered so non-negotiable in critical care today. You have to provide external substrate because the body is prevented from efficiently using its own stores while conserving muscle. Hashtag B, fluid balance and hypothermia.
Okay, fluid balance. It's notoriously tricky in the post-operative or post-injury patient because, as you said, the neuroendocrine response is naturally trying to conserve salt and water, which seems counterintuitive when we're often pouring fluids in during resuscitation.
That's the classic post-operative fluid management headache, isn't it? Hormones like ADH, antidiuretic hormone, and aldosterone are surging, telling the kidneys to hold on to sodium and water. This results in that natural post-operative oliguria, the reduced urine output we often see. Pain and emotional stress also stimulate ADH release, compounding the effect. Now, when we resuscitate these patients, often with large volumes of saline-rich crystalloid fluids, we dramatically exacerbate this underlying tendency towards fluid retention. We're essentially pouring salt and water into a system that's already primed to hold on to it. And the danger here isn't just swollen ankles. The real problem with excessive salt and water retention is severe visceral edema. Fluid accumulates in the walls of organs, particularly in less compliant spaces like the stomach and the bowel wall. This gut edema leads directly to reduced gastric motility, ileus, delayed tolerance of feeding, and consequently it prolongs the catabolic state and the overall length of hospital stay.
This mechanism is exactly why modern fluid management guidelines stress careful, goal-directed limitation of 5E crystalloids, aiming to avoid net positive fluid balance and weight gain after the initial resuscitation phase. The data showing this reduces complications and speeds recovery is really robust now.
Right. And moving on to temperature, hypothermia feels like such a basic thing to manage, maybe even trivial sometimes, but its impact on amplifying the stress response is actually enormous.
The metabolic cost of being cold is staggering. Even mild hypothermia, just a degree or 2 Celsius below normal, triggers a massive increase in the production of adrenal steroids and catecholamines. Physiologically, the body is desperately trying to generate heat, mainly through shivering, which demands huge amounts of energy and oxygen consumption, thus directly fueling catabolism. Clinically, this stress significantly increases the risk of post-operative cardiac problems like arrhythmias, and it also impairs coagulation, leading to more bleeding. The evidence here is really overwhelming. Actively maintaining normothermia, keeping the patient warm during surgery and in the early postoperative period, has been clearly shown to reduce wound infection rates, minimize cardiac complications, decrease bleeding, and lower transfusion requirements. It's a fundamental pillar of reducing the overall catabolic stress response and blunting that neuroendocrine activation. It's not optional, it's essential care. #C, microcirculation, tissue edema, and endothelial function. And that systemic inflammatory response, the SRs, has a direct physical and functional impact, right down to the level of the tiniest blood vessels, the microcirculation, mainly through those induced changes in permeability.
Can you just walk us through the final mechanism behind that capillary leak again and how it directly impacts oxygen getting to the cells?
Sure, so the systemic inflammation, driven by cytokines, kinins, excessive nitric oxide, NO production, causes the endothelial cells lining the capillaries to retract slightly, opening up gaps between them. This makes the capillaries leaky. Fluid and plasma proteins, especially albumin, then leak out of the vascular space and accumulate in the surrounding tissues, creating edema. This edema has direct consequences for organ function. In the lungs, it increases the distance oxygen has to diffuse from the alveoli to the capillary blood. In the kidneys, the interstitial swelling can impair function. And interestingly, as the extracellular space swells with this leaked fluid, water can actually be pulled out of the cells themselves to try and maintain osmotic balance, leading to intracellular dehydration, further messing up cellular homeostasis. Ultimately, if the endothelium, the lining of the blood vessels, becomes too damaged or dysfunctional due to this excessive inflammation, the entire microcirculation is compromised. You get poor blood flow, sludging of red cells, impaired oxygen delivery at the cellular level, leading to cellular hypoxia, and that dramatically increases the risk of progression to full-blown organ failure. The endothelium is ground zero in many ways.
Which brings us right back around to glucose control, connecting the dots. We said earlier that hyperglycemia makes inflammation worse. How does keeping blood sugar under better control specifically help protect that fragile endothelium?
Right, so appropriate blood sugar control, usually with an insulin infusion, is thought to have direct protective effects on the endothelial lining itself. One proposed mechanism involves nitric oxide. Hyperglycemia seems to increase the activity of an enzyme called inducible nitric oxide synthase, or INOS. This leads to excessive, uncontrolled NO production. While some NO is good for vasodilation, too much contributes to that increased capillary permeability and harmful vasodilation seen in shock states. By controlling the glucose levels, we might limit this excessive INOS activity and damaging NO release. This could help preserve the integrity of the microvascular barrier, reduce leakiness, maintain better microcirculatory flow, and ultimately reduce the risk of endothelial compromise translating into organ failure. So controlling the patient's sugar isn't just about preventing ketoacidosis, it's fundamentally about protecting the plumbing of the entire circulatory system from the damaging effects of inflammation. #tag outro. So we try and synthesize this whole complex picture for you. The clinician listening, the pathway becomes clearer, doesn't it? An injury, whether accidental trauma or planned surgery, triggers the release of DAMPs from damaged cells. Those DAMPs then activate both the neuroendocrine axis, cortisol, adrenaline, and the cytokine axis, IL-1, IL-6, TNFA, initiating SIRS. This coordinated, though often excessive and ultimately detrimental, response leads to that massive reprioritization of the body's resources. We see severe catabolism, driven primarily by that destructive Ubiquitin-Proteasome pathway in muscle, and we see significant compositional changes, hyperglycemia due to insulin resistance, widespread tissue edema, and dramatic fluid shifts fueled by that high transcapillary escape rate from leaky capillaries.
Yeah, and understanding this intricate, aggressive, and highly interconnected system really validates the huge paradigm shift we've seen in modern surgical and critical care. It completely confirms the rationale behind things like stress-free, perioperative management, ERES protocols aiming to minimize the initial hit, and our constant, multifaceted battle against all those secondary insults, things like preventing sepsis, avoiding hypothermia, controlling pain aggressively, and avoiding unnecessary starvation. The goal, at the end of the day, is always the rapid and effective restoration of a stable internal environment, achieving homeostasis again to minimize that destructive catabolism and allow true anabolic recovery, true healing, to finally begin.
And I think the sheer complexity we've uncovered today, the redundancy built into the inflammatory pathways, a mirror image existence of both SIRS and CARs, and overlying all of it, that significant patient-specific genetic variability and response intensity, it really underscores why finding generalized molecular therapies, those magic bullets, has been so challenging, especially in the acute setting. It forces us back time and again to optimizing fundamental clinical care.
Which really does raise a crucial question, maybe the provocative thought for us to leave you with as you head back to the wards or the ICU. Given the immense difficulty in trying to therapeutically block specific redundant molecular pathways and acknowledging that genetic variability are personalized diagnostics the next crucial frontier, are we moving towards a future where we can use rapid genetic screening or maybe sophisticated biomarker panels early on to identify which specific inflammatory trajectory a patient is heading down? Can we tell if they're aggressively trending towards severe SIRS and early MOBS, or if they're perhaps leaning dangerously into CARs and immunosuppression? Could that kind of personalized insight finally allow us to optimize our critical care strategies with more tailored rather than generalized treatment protocols? Something definitely worth thinking about as you review the metabolic journey of your next complex postoperative or trauma patient.